Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And I want to welcome you today to the Journal Club, August Journal Club. So thank you all so much who have joined. I know many of you are actually either on holidays or just soon returning from holiday, including our speakers. And some of our fellows. So I really am very, truly appreciative of you setting the time aside for this Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording. So we ask that everyone please keep your microphones muted so everyone can hear the presentation. And if you're having any difficulties or questions, please send a message in the chat and our technical support team will assist you. As always, we want to encourage questions from the audience. We want to encourage participation and we look forward to your questions. Please add them onto the chat function, and throughout the session, we will be asking those questions to our speakers. So on to this month's lead article. It is titled Outcomes of Minimal Residual Disease at Upfront Debulking Surgery Compared with Complete Cytoreduction After Neoadjuvant Chemotherapy. Today we have Martina Angeles, who is in Vall-d'Hebron in Barcelona, and of course, obviously, Alejandra Martinez, who is in Toulouse Cancer Institute in France. Always love speaking with them and hearing their discussion. Encourage everyone to hear their podcast for this particular article as well. So I want to welcome and thank them again for their time. And I know Alejandra just returned from her holiday just yesterday, so really appreciative of your time as well. Now we're going to go on to a brief presentation by Martina, and then we'll get on to the questions from our fellows and our audience. Thank you. Thank you both.
Thank you. Thank you, Pedro. Thank you very much for your kind presentation and also for giving us the opportunity to present our study. So, as you said, this is the title of the study: Outcomes of Minimal Residual Disease at Upfront Debulking Surgery Compared with Complete Cytoreduction After Neoadjuvant Chemotherapy. So, the aim of our study was to compare the surgical complexity, postoperative major complications, and survival outcomes between those groups. Patients with minimal residual disease after primary debulking surgery and those with complete cytoreduction at the time of EDS. So we conducted a retrospective study, including 4 European centers. We included patients with advanced stage disease, 3C4. We included 549 patients, and we compared 2 subgroups: the patients who had PDS with minimal residual disease and the patients who had EDS with complete cytoreduction. We found that the rate of patients with an analytic score above 8, so a high surgical complexity, was 61% in the PDS CC1 group and 41% in the EDS CC0 group, but this difference was not significantly different. And the rate of major postoperative complication was almost 30% in the group of PDS who had CC1 after surgery, and it was almost 20% in the EDS CC0 group, but these differences were also non-significant. Regarding the survival outcomes, we found that both groups, PDS and CC1 and EDS and CC0, had similar survival outcomes in terms of DFS and OS. So we concluded that patients with primary debulking surgery with minimal residual disease and those with interval debulking surgery with no disease after surgery had similar survival outcomes, and that we suggest that interval debulking surgery should be considered when achieving absence of residual disease is challenging at upfront surgery. And here you can see this is our visual abstract. And now we can start.
Right. Well, Martina, thank you so much for the presentation, and of course, obviously, always a question that comes up in discussion of these patients when we are seeing patients and determining whether we should proceed with primary surgery versus neoadjuvant chemotherapy. Do we go at the primary debulking even if there is some residual disease that remains behind? So I'm glad that you have and your team have brought up this question for discussion and evaluation and presented in this article. So we'll get to some of the questions from our fellows first. And we'll start with, we'll go to Filippo in Italy, who's enjoying his holidays. So Filippo, please go ahead and proceed with your question.
Thank you, Professor Ramirez. So your study introduces minimal macroscopic residual disease as less than 2.5 millimeters according to CC score. What was the rationale for selecting this more stringent threshold instead of the conventional 1 centimeter cutoff used in prior studies? And why should this residual disease classification system be adopted widely in clinical practice?
Oh, okay. I answered this one. Thank you very much, Filippo, for this question. It's a very interesting question indeed. Well, we use the CC score, which is used also in other peritoneal malignancies, because we believe it's a more precise cutoff, no, than less than 1 centimeter or more than 1 centimeter. And indeed, there is evidence showing that a residual tumor between 1 millimeter and 5 millimeter has a better survival than patients with residual disease between 5 millimeters and 10 millimeters. So the size of the residual disease has a prognostic impact, and we believe that it should be used like this. So using CC1 allows us to select a group of patients with minimal residual disease, but measurable residual disease. No? And indeed, in our institutions, when a patient ends up with CC1 after PDS, it's usually due to tiny bowel implants, no, that are difficult to resect and usually are millimetric.
So I wanted to actually just follow up and love to hear Alejandra's input on this as well. And, you know, this is a point that we've always had in terms of discussions as it pertains to the evaluation of residual disease. You know, when talking about residual disease, of course, obviously, I think it's much easier and accurate when we designate R0, because you know, there's some who would likely argue against R0, but when you designate a patient that you have completely removed all gross residual disease, that's very obvious in most cases. How do you get to the definitions of these measurements with regards to 5 millimeters residual disease versus, you know, 10 millimeters residual disease versus 6 millimeters residual disease? So how do we conform to that level of accuracy? And I remember many years ago, we actually did a prospective study when I was at MD Anderson and in conjunction with Sloan Kettering, where we took patients where we said at the completion of surgery, and this was a prospective study. So at the completion of surgery, anyone that we categorize as optimal, and back then optimal was less than 1 centimeter, anyone that we categorize as optimal, we're going to get imaging studies within 28 days of the surgery, and we're going to see exactly whether we were optimal. And we were wrong. At Memorial Sloan Kettering and at MD Anderson, 50% of the time, when we said we have done an optimal surgery less than 10 millimeters, there was disease that was way bigger than 10 millimeters. So again, kind of a long question, but I think it's relevant to this, like this concept of the measurements of residual disease.
So what I don't understand the exact question, but
how do you know it's like 2.5 or not 5 millimeters or?
Yes, it's true. You can measure it, but it's true that usually you do it like an eye calculation. Well, most patients are CC0 with at the end it's the same, that residual tumor 0 and CC0 means the same. So I think that we use the same score, but I think that really using this and doing this differentiation is important, because usually you do not leave 1 centimeter disease. No, usually you leave smaller lesions. Now,
Yeah.
what do you think, Alejandra?
I fully agree with you, Martina. I know that kind of studies, Pedro, and I think that surgeons were very optimistic.
Right.
But the truth is that at least in our institutions, we usually go for surgery when we are sure that we can do like a complete procedure. And the only cases where we can leave residual disease are those patients who have like very really small millimetric disease on the bowel, like small miliary disease on the bowel. I think this is the only situation in which we would undergo a cytoreductive surgery. I'm talking of high-grade serous histology. And of course, this is subjective, but well.
Perfect.
And
Yeah.
if the residual tumor is higher, then we would have given neoadjuvant chemotherapy first. Yeah.
Excellent. Great. And we'll get on to some additional questions as well. I think the next question is really important and relevant because, of course, obviously, when we talk about survival in patients with ovarian cancer these days, it doesn't just depend on surgery and carbotaxol. So with that, we'll go to Sofia Bigardi in Italy.
Thank you, and thank you for the presentation. My question is, given that PARP inhibitors were not included in the treatment protocol during the study period, how might the incorporation of maintenance therapy with PARP inhibitors, for example, in HRD-positive patient, impact the applicability of these results to the current clinical practice?
Yes, okay, thank you.
Martina,
Thank you
do you
very much.
ask?
Yeah, yes, I will also answer this one. This is also a very, very interesting question. Indeed, our patients were included between 2008 and 2015. So this is an old study, and the patients did not receive maintenance therapy, as you said. And probably there are more patients BRCA mutated or HRD positive in the EDS-CC0 group, no? So these patients would have been nowadays treated with PARP inhibitors, and we might observe an additional survival benefit in the EDS-CC0 group because of PARP inhibitors. So it's possible that PARP inhibitors would have increased the survival advantage in this group. And probably this would simply reinforce our idea that if you cannot achieve complete site reduction upfront, it is better to perform neoadjuvant chemotherapy.
Excellent. Do you want to add anything, Alejandra, to that?
No, I fully agree with Martina. She has very well explained the question.
Perfect. So we do have questions from the audience. And again, we want to encourage further questions from the audience. I see also he's on a holiday because he's looking great. Julio Bonaldo, former fellow. Julio, you want to go ahead and ask your question?
Yes, thank you, Pedro. So first of all, congratulations to Dr. Angeles and Martinez for your work. So my question is that patient in your study, patient with a PCI inferior to 10 at the time of surgery had significantly better outcomes. So do you believe that initial PCI correlates with survival outcomes or not? Thank you.
Do you want to answer, Alejandra?
Yes, the question if initial PCI has a prognostic outcome, Julio?
Yeah, exactly.
Yeah. Okay. Yes, this is a very interesting question. So in our study, we did not have the PCI at baseline for all patients to compare the survival outcome when the patient was operated on upfront surgery compared to interval surgery. But we do believe that tumor burden is correlated with survival. And this is supported by several studies in the literature. There's a big series from MSKCC. We have also published 2 papers in Gynecoloncol and Journal of Gynecoloncol showing the prognostic effect of tumor burden in patients undergoing complete surgery. And there's a recent paper from our colleagues in Paris, from Sébastien Gouy, from Gustave Roussy, also showing that there's a linear correlation between the tumor burden and survival, both for patients who undergo primary cytoreduction and for patients who undergo interval cytoreduction. But the thing is that we do not know if these patients who have low tumor burden, for example, if we put a cutoff at 10, even if this is arbitrary, we do not know if these patients with a low tumor burden at diagnosis, we do not know if they do better if they undergo primary compared to interval cytoreduction.
Thank you.
Excellent.
I
Thank you
understand.
for the question, Julio. And then we'll go to another former superstar of our fellowship, Dr. Irina Cibulak from Austria. Irina, please go ahead and ask your question.
Hi, Pedro. So nice to see you. Thank you. And congratulations to the study. I think it's a 1 million question, what we ask every day we go to the theater. So my question is, if we have this situation where we know we will end up surgery with some residual disease because of small nodules on the bowel serosa, what do we do with peritonectomy? Should we leave this disease of the same diameter because at the end, it's the same residual disease according to our classification, or would you complete the peritonectomy in this case?
Do you want to respond, Martina, or do
Yes, as one, in my opinion, you should remove all the disease you can. You leave it in the bowel because you are not able to remove it. But at the end, if you leave it, it will be in total, overall, more tumor burden. So I really believe we should remove it. Now, what do you think, Alejandra?
Martina, if you have a patient right now, tomorrow, if you have a patient, even if she has a good condition, she has peritoneal carcinomatosis and bowel disease in the bowel, and you see that during your laparoscopic assessment, would you go for upfront cytoreduction or would you give her neoadjuvant chemotherapy? I think this is Irina's question.
I don't know if this is a question. I think that the question is if you do the cytoreduction.
If you exactly. So you do this. You decided to go upfront, and you know you will have some residual disease of some millimeters because of the small bowel cirrhosis. So you cannot remove it. What do you do with the peritoneum? On the diaphragm or whatever, where you have disease, but the diameter of these nodules is the same as on your small bowel serosa.
Yes.
So in the end, if you leave both, it's the same classification. It's residual disease under 5 millimeters. So how do you proceed here?
So we will do probably neoadjuvant chemotherapy, but if not, we will remove it. I think as much tumor burden as possible.
Yeah, I agree with Martina. I mean, in these patients, well, in our institutions in Barcelona and in Toulouse, we usually do laparoscopic assessment. So this patient, I think we would probably do neoadjuvant chemotherapy if she has small bowel disease that's not resectable. But if we're in our surgical procedures, and sometimes it can happen that we do our laparoscopic assessment, we have an ornamental cake, and we're not able to explore the bowel. So we can start our extraperitoneal approach, do our beginner surgery, and then say, wow, she has very small nodules in the terminal part of the ileum. What should I do? I absolutely agree with Martina. I would perform all my surgery, remove all the disease except for those small nodules. And if there is if they're limited in our institutions, we usually treat them. I mean, we're not coagulate, but we destroy them.
Argon laser?
Yes.
Yeah, the argon beam.
Sometimes there are so many that even if they're very small, that's more difficult.
Usually not argon laser. We use now fulguration with our roller ball.
Mm.
On
But you can do yes.
the same.
Yeah, you can do
Same,
whatever.
yeah.
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 Okay.
Great, excellent.
Thank you so
Thank
much.
you for your question, Irina.
Thank
And then
you.
I see Natalia has joined us. So we'll go to Barcelona, Natalia Tejera.
Hello, thank you so much for the wonderful paper.
Espelho horas with that.
As we move toward a more personalized approach in ovarian cancer, do you think that molecular profiling, such as HRD or BRCA mutation status, could eventually impact not only systemic therapy decisions, but also the
Está bien,
choice
o
between
ya no sé
primary
something.
debulking and surgery and neoadjuvant chemotherapy?
I answered this question, Martina?
Yes, please go.
Okay. Thank you very much, Natalia, for this question. I think it's a very interesting question. And I think that genetics status and biologic information will impact surgical decision in the future, because right now I don't think we have enough data to base our surgical decision on this, because even if patients with BRCA mutation or even for all HRD patients are more sensitive to chemotherapy, and then I know that there are small retrospective studies suggesting that BRCA mutated tumors have greater benefit from neoadjuvant chemotherapy followed by interval cytoreduction. I think there's not enough data to limit the surgical effort or to modify our surgical strategy to say, well, because she's the tumor is BRCA mutated, I'll give her neoadjuvant chemotherapy. And the majority of these patients are younger. And we also have the results from the PARP trials showing that the best survival and also the best benefit from PARP inhibitors are in patients who undergo complete primary cytoreduction. We have the result from the SOLO-1 trial that showed benefit for olaparib across all groups in the BRCA mutated patient, but demonstrated that patients with no residual disease after upfront cytoreduction had the best PFS. And we also have the data from the Paola trial showing similar results, showing that residual disease negatively impacts survival in HRD tumors. And they also reported that the higher survival outcomes were in patients with HRD tumors after complete primary cytoreduction. And I'm thinking also of a trial that was published by the Mito group several years ago, and the majority of patients did not have PARP inhibitors. In this trial, residual disease was the most important prognostic factor, and it was independent on the genetic status. And of course, we should wait for the subgroup analysis from the TRUST trial that will probably give us more answers to this question.
Thank you.
Thank you, Natalia.
Very, very well. So next we'll move over to Heidelberg Hospital, University Hospital, Frederic Streich.
Hi, everyone. Thanks for the great presentation. So my question is quite practical. So you mentioned the lack of information on the decision-making process for choosing primary versus interval debulking surgery as a limitation of the study. I would be interested in your own clinical approach in making this decision. So which criteria, imaging, diagnostic laparoscopy, performance status do you primarily rely on? And do you usually perform diagnostic laparoscopy?
Okay, if you want, I answer this one, Alejandra.
Okay.
We love to hear actually what you do at each of your institutions. You're two major centers in Europe.
I think we do.
Hopefully, it's pretty similar.
Yes.
But yes, we always perform a diagnostic laparoscopy before surgery to obtain a histological diagnosis, but also to assess the resectability. I think that only in frail patients in whom you really know that there is a risk of the surgery, we prioritize an image-guided biopsy. But even in those patients that we know that they will have neoadjuvant chemotherapy, we try to schedule a diagnostic laparoscopy before starting chemotherapy. And this, I think, this allows us to obtain larger biopsies. We usually, I think, in both institutions, record a video of the disease distribution, and this will lately allow us to compare, the disease, the response to chemotherapy, like looking the videos, and it's better even than reading the operative report, And also regarding the strategy that we use, we usually try to do like in 2 steps. We published the manuscript also with Alejandra a few years ago about our strategy. We do it in 2 steps. So we do one day the diagnostic laparoscopy, and another day we schedule the laparotomy if the patient is resectable, And this allows us to have the histological diagnosis. So this is also recommended nowadays. And also we can also counsel adequately the patient regarding the procedure she will undergo. And also this allows us to avoid like preoperative preparation with peridural anesthesia, the IV access and everything that you need for a laparotomy. It's not the same that for a laparoscopy. So usually we try to do it in 2 steps. And well, then the decision on the resectability, well, it depends, of course, on the patient's conditions, but we try in young and fit patients, we always try to do upfront surgery, even if it requires multivisceral resections and extended peritonectomies. We try to do it always.
Yeah.
And then also as a follow-up question to that, Martina, I was wondering, if you're doing routine laparoscopy on these patients that have clearly advanced high volume disease, are you doing anything to prevent port site metastases? Because I mean, these are patients that are like at highest risk. They have ascites, they have tumor all over their peritoneum. You're placing 5mm ports that are the highest risk of port site mets. Are you doing anything to prevent it?
Yes, this is a very good question, because this is something that actually happens, and particularly when you do to access the cavity, you do an open laparoscopy instead of a verse needle. It happens more frequently. I think it's important to close the fascia very well to avoid that, because the port site metastasis probably happen when there is a lot of ascites. It happens more frequently, and we always put the trocars in the midline. Because in case of port site metastasis and primary debulking surgery, we will resect the trocar, the metastasis, And if we put laterally the trocars, then this will damage the abdominal wall. So we try to put it always in the midline.
Okay.
And if you can use small trocars, I think this is also better, but also try to close the fascia.
And Alejandra, anything you wanted to add?
No, we do the same as Martina. She has been working with us for years, so we do exactly.
So she learned well.
She's a good.
Oh. Excellent, fantastic. Okay, so the next question was from Mariana Carvalho from Sao Paulo, Brazil, but she could not join us, so I believe Frederica is going to ask.
Yeah, I'm happy to ask her question as well. It's going into the same direction, actually. She's asking, how do you predict with imaging or laparoscopy that a case could be CC1 in primary debulking surgery, but a CC0 in interval debulking surgery? Any practical suggestions?
How can we predict CC1? Well, CC1, as we have previously discussed, is usually because we leave very small residual disease on the bowel, and this tiny disease on the bowel is very, very difficult to see on CT scan. I mean, you're not going to be able to see it. And even on PET-CT, it is very difficult to see it. We performed one study like 2-3 years ago, in which we compared the PCI with the abdominal regions and a PET-CT PCI, and the bowel was the region in which PET-CT was less sensitive. So it's very difficult to see small disease in the bowel in imaging. But I think laparoscopic assessment is an excellent tool to explore the bowel and to explore the miliary disease in the bowel. Of course, you can have addition sometimes, or you can have an mental cake and you cannot see your bowel, but we usually use laparoscopy to explore and to see that patients do not have miliary disease in the bowel.
Okay. So I think that next question, first of all, I have to commend our next fellow also as well, not only because of the submission of her questions, but also the fact that it is 2 a.m. in Sydney, Australia. So Helena, next is your question. Helena is joining us from Sydney, Australia.
Thank you so much. 93% of the cases in your cohort were high-grade serocytology. Would you still recommend neoadjuvant chemo followed by interval debulking in other cell types that may have CC1 at primary debulking surgery?
Thank you very much, Helena, and
an easy question.
An excellent question. And congratulations for your commitment in the journal. Pedro must be very, very happy. So it's really a very interesting question. I don't know if I have the answer, at least for all histologists, but given the lower sensitivity to chemotherapy, I think that we should always consider upfront cytoreduction for non-high grade epithelial ovarian cancer, and of course to achieve complete resection, even if we have to do a larger surgical effort, if we have to perform a more radical surgery. And of course, these patients must be treated and operated by expert surgical teams. But your question was, what would you do if you have minimal residual disease, CC1, that you cannot remove? So I would go for upfront surgery, but I think there are probably differences depending on the histological type. So for low-grade zeros, certainly I will go for upfront surgery, even if I cannot achieve complete surgery, or if I live like less than 1 centimeters. Primary cytoreduction. For clear cell tumors, this is less evident, and I would probably consider neoadjuvant chemotherapy with early evaluation. And for mucinous advanced ovarian cancer, well, this is very rare. Primitive from the ovary, the majority are like metastatic from GI tract or gallbladder. And the prognostic outcome is very poor. So we have to try to do upfront surgery in all cases. But if we have residual disease, I think that we have to individualize depending on the procedure, the complication risk, as they have, as I said, very poor survival, even if you do a complete upfront procedure. I don't know, Pedro, what are your thoughts about this question?
No, I completely agree, and particularly, of course, obviously, as you mentioned, mucinous tumors, it's very rare that that we know that they are primary from the ovary, and we don't really have very good regimens for the systemic therapy for those tumors. So I think that, and particularly for mucinous tumors, and often for low grade, those patients often are very symptomatic from their disease because of significant amount of ascites. So I think every effort to proceed with primary cytoreduction, it's very sensible. Clear cell, I agree. I think that clear cell we treat as if not operable according to the standard criteria, then we would give neoadjuvant chemotherapy. So yeah, definitely agree with that. So next question is from Lebanon, Reem Abu Shakra.
Hi, sorry. Thank you for this presentation. And my question is, could the use of intraoperative frozen sections help distinguish between fibrosis and tumor or determine surgical completeness in the IDS group? Additionally, if we have some residual tumor nodules clustered in critical locations like mesenteric root or porta hepatis, can we consider replacing resection with ablative modalities such as electrofulguration?
Okay, I will answer this one. Very, very, very interesting. Thank you very much. So regarding frozen section, the first part of your question, I believe it may help in these situations. Now, I've used sometimes this strategy in cases in which you cannot see clear disease, but at the same time, the scars in the peritoneum are thick, or it's like there is a little bit of fibrin, and you don't know. And in these cases, I think it can help, and I think that we might be surprised because sometimes there is disease, even if we think that there is not. No, but if you do not have the options of doing frozen section, I think that in case of doubt, you have to remove the scar also, if you think it's only a scar, but you have doubts. And then, yes, regarding the other part of your question, the ablative modalities, yes, I think this is also an option, but I think it's very important to use to adequately use this technique to completely eliminate the disease. Now, what I mean by this is that you cannot do like a superficial fulguration of the lesions and think that this is okay. No, I think that, for example, if you have lesions in the mesentery, you fulgurate these lesions, but you have to do it until you destroy completely the lesion, the peritoneum, and you are not able to see or to touch the lesions. Okay, you have to do a complete destruction. And if you are not able to destroy the lesion, then you should say, okay, this is residual tumor, and you should put it in the operative report with the exact size and the exact location.
Okay.
Excellent. And we'll proceed now to Marina Rossano from Milan.
Thank you for your presentation on such a relevant and much debated topic. So despite emerging evidence showing similar survival between PDS-CC1 and IDS-CC0, many centers still favor primary debulking approach when technically feasible. So my question is, should we begin to reconsider this paradigm, prioritizing lower surgical morbidity and patient quality of life through interval surgery in some selected cases, even when primary debulking surgery is an option?
Should I answer, Martina?
You want? If not, I can answer.
Okay. Thank you, Marina, for your question. Concerning CC1 after PDS, I'm not sure that many centers would favor upfront cytoreduction in this situation. Maybe depends on countries, but even before the TRUST trial results, if we had a patient with a high-grade serous ovarian cancer, and if we saw during the laparoscopy that she had like miliary disease in the bowel, this patient would go to neoadjuvant chemotherapy. But if the philosophy of the institution is to perform a PDS with a CC1 result, so to favor a primary cytoreduction, even if we have a CC1 result, yes, I think that we should shift, we should change, and we should favor neoadjuvant chemotherapy to decrease the surgical complexity, the morbidity, and the postoperative complications. Because as Martina showed in the beginning, this subgroup of patients who have CC1 results after surgery are patients who have higher tumor load. So these patients in our study, they had 80% had a PCI over higher than 10. Compared to 40% for those who were CC0 IDS. And they also had more postoperative complications. So even if they have a similar survival, they have more higher tumor load and higher complication rate. So we should we should treat them with chemotherapy first. And I think that this is more evident after the results of the TRUST trial.
Well, thank you, Alejandra. And we want to get to our last question from our fellows. And of course, you mentioned the TRUST trial, and we're not going to let you go away without actually addressing your thoughts on the TRUST trial, as there are several questions in the audience about the TRUST trial. But Luisa, we'll go with you for our last question from the fellows.
Yes, thank you. So we already talked about the fact that there are several confounders which complicate the transferability of your study to clinical practice, such as the lack of BRCA mutation status, patient comorbidities, and a relatively low proportion of patients who received bevacizumab, and the fact that there was no PARP inhibition available during the study period. So maybe in summary, what do you think? How could your study results still guide us in daily clinical practice despite these limitations?
Okay, I will also answer this one because it's related to a previous that I also answered. So thank you very much, Luisa. So yes, as you said, these limitations are true, and we mentioned them in the manuscript. And even though I think that our results may give us some light. No, we found that survival outcomes were similar between both groups. So then, considering that EDS with CC0 may be less morbid than PDS with CC1, I think that we should prioritize EDS when complete site reduction is not possible. And I think that we should repeat this study with more recent patients who have received no maintenance therapy. But as I previously mentioned, probably this study with PARP inhibitors will benefit even more the survival outcome of the subgroup of patients with EDS and complete site reduction, and it would reinforce our idea to go for neoadjuvant chemotherapy if there is minimal residual disease.
Excellent. So Martina, Alejandra, as a last question, as I mentioned from the audience, several have asked, what are your thoughts on the result of the TRUST trial, the 5th trial evaluating the question of primary cytoreduction versus interval debulking surgery?
I leave you the last question, Alejandra.
Okay, thank you. So what are my thoughts on the TRUST trial? Well, the TRUST trial, I think that the TRUST trial, well, it's negative because it did not reach the primary endpoint of the trial, which was overall survival. But it still showed a difference in PFS, which was only 3 months for in the intention to treat population. But the TRUST trial has also given us showed very important results that we had not seen in the previous trials. We have seen that the biggest benefit from upfront cytoreduction is in patients who stage 3, but in those in which we can achieve complete cytoreduction. So I think that this is the key. The key is to improve the selection of patients to predict complete cytoreduction, because in the TRUST trial, even if the centers were selected, I think that the rates of complete surgery were quite low, were 62% in the upfront surgery group, and also to predict a low complication after postoperative complications. And when we look at the Kaplan-Meier curves, we see that the survival is lower in the first months in the surgical arm, and probably this can explain, or partially, I don't know, by postoperative complications. And we saw in a previous study that we did with Martina, published in Gynecol-Oncol, the survival impact of postoperative complications. So I think this is also a key thing. So I think we should improve selection criteria to exclude frailty, so do a better screening of these patients, and also ensure complete surgery with a low complication risk. So as we have talked a lot about laparoscopic assessment, I think this could help to select the best patients. So patients, I think, who have low tumor burden, and yeah, and this is why in the French collaborative group, the GINICO group, we're submitting a grant for the Lotus trial, in which we aim to demonstrate the benefit of upfront cytoreduction, but in very well selected patients with low tumor burden.
Excellent. Well, thank you so much to both of you. Martina, Alejandra, thank you for submitting your manuscript. Congratulations to your team as well. I want to thank all of the fellows who joined, and congratulate all of the fellows who are completing their fellowship. And then also commend Helena, you're not to join any more journal clubs at 2 in the morning. So congratulations to you on that, and looking forward to the next group of fellows as well. Thanks to those of you who joined and sent in your questions. And I also want to invite all of you for the September Journal Club, where we're going to have Fred Amont, who is going to be discussing the ESGO guidelines for the management of patients with gynecologic cancers during pregnancy. So that should be also a very good topic for discussion. And once again, all of you who have joined during your holidays, go back to doing holiday stuff. So enjoy. Thank you.
Thank you, Pedro.
Thank you.